I'm Clive Priddle. This is The Current. And as you know, The Current is a series of conversations with authors who bring unusual, brilliant expertise on the affairs that are roiling our times. Couldn't be better hands today because talking with me is Dr. Ezekiel Emanuel, who's a professor at the University of Pennsylvania. He's an architect of the Affordable Care Act, and he is the author of several books on healthcare, including recently The $1 Trillion Revolution, which he co-edited with Avi Gluck, and forthcoming, Which Country Has the World's Best Healthcare? Zeke, it's really nice to see you. Thank you for coming today.
Great to be here.
We are, of course, having a conversation in the ongoing coronavirus era. And you and I happen to be talking also after a weekend when there's been a lot of urban disturbance in America following the killing of George Floyd. So that wouldn't seem to have anything to do with healthcare, but I know you think it does, because one of the indexes that you've used to assess healthcare in different countries around the world is how well is it spread throughout a population? Is it just going to an elite group, or is it generously spread throughout all classes and castes of people? So what are you feeling right now about the state of the nation's hospitals, the challenges they face, and how well our healthcare system is going to stand up to an unprecedentedly strange time?
Wow. Huge questions, really
Yes.
ginormous questions. So the first thing is that it's quite clear that COVID has revealed a lot of problems with the healthcare system and how it addresses or promotes people's health. And it has not been, you might say, getting great results. We spend more than any other country by a big amount, close to $1 trillion. And we should be getting much better care. The first thing I would say is we have no path, literally no path to universal coverage at the moment. We thought in the Affordable Care Act, when we constructed it, we would create a way that we could actually get universal coverage, but the Supreme Court undid that by allowing states to opt out of Medicaid expansion without a penalty. And the big problem is we have 14 states that seem implacably against Medicaid expansion, and so we can't get coverage of everyone. Even if we could get those 14 states on board, there are still millions of Americans who, for a variety of reasons, cost reasons, time reasons, the complexity of the system, don't get coverage. And one of the things we certainly learned by studying 10 other countries in addition to the United States, everything from Taiwan to Norway to Germany to France to Australia, is that we have far and away the most complex healthcare system in the world. We need to simplify it. You have to spend a lot of time to figure out which coverage you have to get, and the poorer you are, the more time you do, because if you're well off, you're in a company and there's someone else whose job it is to figure it out for you. You need to figure out doctors, who's covered, who's not covered, what your copay is, where you are in the deductible cycle. It is way more complex than any other place. And that complexity makes it harder for people to get coverage and harder for people to get the kind of care they want. So that's the first thing. The second thing is that spending so much on actual healthcare services means we've underinvested in a lot of the other things that we know are good for promoting health, including good for promoting health among relatively well-off people. So one of the things we've seen from this COVID pandemic is the disproportionate impact on people with comorbidities and the high level of comorbidities we have in the population. So that's had a disproportionate impact on minorities who have, are at higher risk for many of the problems that let you get COVID: obesity, hypertension, heart disease, diabetes. Those are more prevalent in minority communities, but they're not restricted to minority communities. And, more than a third of adults are overweight and obese in the United States. A quarter of the population has comorbidities, whether it's hypertension or heart disease or lung disease, that put them at high risk for COVID. We haven't been good at promoting healthy lifestyles of people that would decrease their risks of problems. So that's another consequence of probably spending too much on very high-tech healthcare and not enough on spending promoting public health measures that we know have a bigger impact on actual health outcomes. So there's a lot that we could do that would improve the system.
You know, you've written in previous books really wonderfully about how, I guess, every country's health system is really a product of its history. You know, that it never starts from scratch. There are certain social traditions that come with the country's history, with its population makeup, with, you know, whether it's a pioneering environment or whether it's a highly static society and so forth. I mean, and America has a very particular kind of medical history, and you've dedicated your entire career to it. But I wanted to ask you, especially since you've done this global survey, if you were given free choice and for a moment you put down your American citizenship and you were allowed to be ill somewhere else, where would you feel cared for you best?
So I think that's a complicated question. It sounds simple, you know, it's like a backdoor way into having me say which country's number one. The first thing I would say is no country's number one, and I think we conclude in the book no country is A+, and isn't in need of some serious reform in some areas. I think there's a collection of countries that are doing well, but I think we also often need to distinguish two kinds of care, which we don't distinguish frequently. And so one is, you know, I get into a car accident, where am I sort of confident I'll get great care from an acute episode? And I think a lot of countries satisfy that, that, you know, if something disastrous happens, you will be cared for and you will get appropriate care. And I think compared to, you know, the way healthcare was even 20 or 30 years ago, that's going to be true in most of the countries we looked at. Maybe not China, for a whole variety of reasons. You have to be in a certain city and you have to be near one of the premier hospitals. They have hospitals by 3 tiers. But I think in most of the other places, the acute care, I'm less worried about that. What I think is the big issue for healthcare today, and certainly in America, is chronic care. So I have a set of chronic problems. Where am I likely to get my chronic care best? And that, I think, is something we don't think about as much. When we think about I need healthcare, it's for the acute problem in the emergency room. But more than 80 cents of every dollar in the United States and almost every developed country is really spent on chronic care: diabetes, cancer, hypertension, heart disease, lung disease. Those are the problems. And there, what you really need is you need a good primary care doctor, and you need a primary care doctor who will coordinate your care to specialists, and that you will get all of the illnesses you have in one place, with not waiting for you to show up, but more proactive outreach to you to help you manage it. And I think we're less focused on that as the measure of high quality care. And I do think that there are countries that do that best. Some of them do it best because their doctors don't take care of that many patients, and they've created a good divide between the primary care doctor and the specialist, and the specialist is really a consultant to the primary care doctor. You see that commonly in the Netherlands and in Norway. Some places have created that because they have, you know, excess capacity, as it were, a lot of doctors and therefore a lot of attention, and it's just much more focused. I think the next phase of quality of care is really going to be, can I get the care online, at home, at my convenience? And I think, you know, COVID has pushed us in that direction. Certainly in the United States, it's pushed us very heavily to more online, more home, less hospital bound. I think how that gets solidified, how that gets retained in the system is going to be critical. And to get it retained in the system is going to require payment change. And that's really what I'm working on now, is how can we pay for the healthcare differently so that the gains we've gotten through COVID in terms of more telemedicine, more home care, aren't lost when hospitals try to rush back and do a lot more procedures in the hospital to make money. And I think that's going to be the critical question over the next 4 or 5 years in the delivery side of healthcare.
Zeke, thank you so much. Really appreciate
Great.
it. Great to
All
see
right.
you.
Fantastic.
Hang in there and fix the system.
Hachette,